Hello, my name is Dean Morgan, as you were just told. I'm not sure I do the lion's share of the treatment, but I am involved with our therapist teams and obviously with our orthopedic and physiology program as well. Um, so as we said, useful evaluation and treatment strategies. They'll be brief, but I think the benefit of this is to remind us as therapists. I know we have some parents out there, some patients out there. I'm primarily speaking to the therapist, but there is information there for all of you, so don't turn off just yet. On improving strength, power, and performance. When we talk about strength, we're talking about how much force an individual can produce through their muscles, their legs, their arms, their trunk. So with our kids with CP, the tone takes over their movement. They're not really allowed to move in the direction or at the time that they want to move. So it's up to us to figure out how to make that more accessible to them, whether it be by us using Botox to weaken some muscles for a time that we can get other muscles stronger, or whether we use our orthopedic expertise to get better alignment. So when we do activate these muscles, they do what we need them to do when we need them to do it. And then talking about power. Power is just how much work they can do over a distance and then divided by time. So if you want a patient to be more powerful, you either have to decide and figure out a way to get them to be able to generate more force, or you have to figure out a way for them to do what they're trying to do at a quicker speed, so less time. So if you have quicker or you have more force, more muscle buildup and activity, they will be more powerful. Our APTA tells us that physical therapists are movement experts who optimize quality of life through prescribed exercise, hands-on care, and patient education. So all those things are involved in how we try to benefit our patients. Physical therapists teach patients how to prevent or manage their conditions so they will be able to achieve long-term health benefits. Now we teach patients and we teach their caregivers. We examine each individual and develop a plan using treatment techniques to promote the ability to move, reduce pain, restore function, and prevent disability. Now, reducing pain is definitely on the top of what we try to do. So if you're doing work with a patient and there's pain, you don't try to push through that pain. Those of us who work with this population know that some of them may be nonverbal, but knowing your patients, you typically can tell if there's pain, if there's discomfort, if they're having a bad day. So when we work with them, we try to keep all those things in mind. In addition, PTs work with individuals to prevent loss of mobility before it occurs by developing fitness. So over time, our patients can tend to lose their mobility, whether it be able to turn in bed to relieve pressure, or whether it be them walking across the room. A sidetrack, there was a question for Dr. Kim about a patient who was GM-FCS level 4 and 5, who was given Botox, and the individual who sent the question said that they didn't see any functional change. We don't know the patient, we don't know the circumstances, but one of the things I know in dealing with Dr. Kim and having her work with my patients, your expectations of what Botox and of what your skill can do have to be reasonable. So again, not knowing the patient, if the thought was this person gets Botox, they'll be free to move in an instant and then they'll be able to walk across the floor. Again, I don't know these circumstances, but we have to, again, think of reasonable goals for our patients and figure out a way to get there or get as close as we can reasonably given our expertise, their status, and what's available to us. And it does take some time. I mean, we didn't talk about the time frame, but if there's a patient who needs Botox, it's typically not just one treatment and they're done. It's a stepwise process to improve their situation, whether it be initially to loosen up and decrease some pain, and then to get stronger. So getting a patient stronger doesn't happen that quickly. We need to give it time and have the resources to make that happen. When we're treating at home, in school, or in the community, to help our patients, we'd like to have better efficiency with their gait so that they're not putting out so much energy just to get from point A to point B. Again, with safety, whether it be on stairs, transferring to a commode, or into a car, we want to try to promote and make it accessible to them to have safe transfers and safe navigation. Our patients, they do fall. So avoiding that or not paying attention to that is a disservice to them. So I frequently get my patients on the floor. The ones who are higher functioning, I throw them on the floor in a good way. And they learn how to protect themselves. I teach them how to do that the best I can. You want to minimize their inequity when they're dealing with their peers. So if a child has an issue running across the floor or staying seated when they're playing with their peers or interacting with their peers, if we can address that, it's a really good thing that we can bring to their situation. An economic use of our therapy interactions. So when the child comes to work with us, the time we spend should be geared towards getting the best out of that time, whether it be 15 minutes out of class, a half hour in your therapy practice, or an hour in your therapy practice, or an hour in their home. You want whatever time you spend with them to be optimized to benefit them for that interaction. Some of the things I'm speaking about refer primarily to GMFCS levels 1 and 2, which are children who don't need an assistive device like a brace or some sort of support. Some of them who have AFOs, but we can also push it to those people who are using, those children who are using walkers, maybe a gait trainer, maybe spend 50% or more of their time in wheelchairs. So it's not beyond working this way with patients who spend some time in a wheelchair. You can still work on control of their trunk, control of their body, control of their center of gravity, and get them to be able to tolerate more when they're doing their daily activities at home. And last but not least, you want them to have fun. I've not been accused of having the most fun with my patients in that they have fun. I'm not a sticker person. I'm not a toy person. But when my kids come to work with me, they run down the hall to get to our session. You'll see in some of the video laughing and enjoying themselves. But for me, again, this is me personally, I'm not that guy who's going to spend time with stickers and toys because it takes away from my work time, my patients' work time. I'm sorry, give me a moment just to get the video working properly. So the tools that we've been taught in school that are really helpful, just depending on how you look at the information you get from these tools. The Thomas test. It's a simple, very transportable way of looking at our patients' bodies. So how is it helpful for us? When you do a Thomas test, the first thing you do is you bring the knees toward the chest. Not up to the shoulders, not into the chest, just about the height of the sternum. So you're looking to see if that patient's pelvis lays flat on the table. If that pelvis rolls up right away, you know they've got a lot of tightness through the lower back and the fascia of the thoracolumbar spine. So just that simple movement, you see if there's any restriction that's there that you need to address moving forward with this patient. And again, when you're doing the test, you hold one knee up, lower the leg, and you're looking to see, does the thigh touch the table? Does the thigh drift off to the side, or is it center? Does the knee extend, or is the knee forced to be flexed because the quad has some tension on it? So you're looking to see all those structures that could interfere with your aligning this patient for work while you're trying to get them stronger. And if you don't address those tightnesses, that fascia, you're really putting them at a disadvantage to get the most benefit out of your treatment. When you're looking at gastroc soleus, remember, and again, it's a simple thing, but we want to make sure we look at all those little details. Knee bent versus knee straight. When our children are walking down the stairs, if they can't keep the top foot in touch with that step, and you don't recognize it's a soleus issue in addition to a gastroc issue, then you're not, again, doing your due diligence in helping them address the problem. And there's some things I'll talk about later on that also involve soleus and gastroc. There's another scale that's available. It's called the Pediatric Balance Scale. It was developed at the Shirley Ryan Ability Lab, and it's the Research Institute of Chicago. That's their old name. There's a link to that scale at the end of my talk. You will have access to that, so please look at that when you're done. And one that I did myself, well, I used, which is very simple, a single step test. Let's go to the single step test first. The X is their center of gravity. If I have a child stand with their back against the wall, and they take a single step forward and back, knowing whether they can actually do that weight shift to control their motion, or whether they can't, gives you an idea about what things to work on with them. They've got a secure wall behind them. They've got you in front of them, hopefully where you need to be to protect them. And you see whether shifting their weight is even accessible to them. If they can't do that, why bother even trying to run across the floor if you can't have a good idea they can control their body? The extreme is the next picture, which has the same figure standing, stepping onto a BOSU. Now you've got this open space, you've got a BOSU, which is not a very stable surface. And then the third dot is them stepping up onto that BOSU on top of, with their center of gravity going up. If you can work towards getting a child that kind of balance, where they're not afraid to be there, but they have the control of their trunk and their stabilizers to do that, you're moving in a good direction to have them be safe ambulators. Let's go back to the two that I skipped. Picture on the left is thoracolumbar fascia. If you do that Thomas test and you find some tightness, those are all the structures you need to look at to see what you need to loosen, whether it be up in the traps, in the lats, down in the low back. All those things can be addressed and still get some benefit from your interaction when they're working with you therapeutically. Top right, you have the iliacus, the psoas, the quadratus lumborum, and I didn't have the rectus femoris in there, but again, the distal to the femur, you have rectus femoris. And when you do your Thomas test, all of those things, depending on what you see, leg out to the side, petra fasciolata possibly, or IT band, leg rotated in, it could be iliacus, it could be iliopsoas, hips flexed and not fully extending, it could be iliopsoas iliacus, or knee flex because you cannot, knee extended. If the quad is tight and that knee can be flexed to about 90 degrees, you need to address those things. Bottom right, we have soleus and gastroc. Gastroc being a 2-joint muscle, soleus being a 1-joint muscle. You can't expect good control and balance if they don't have control over that distal part of their anatomy. These are the criteria that are used in that pediatric balance scale. Looking at what they're looking at, sitting to stand, standing to sit, transverse, standing support, turning 360 degrees, all those things are looked at in the test, but they also give you ideas about what things you can utilize during your therapy session to benefit the child depending on what they do well on and what they have issues with. Looking at the gait cycle. I really like this picture I found that has a circular picture. The only thing I have issue with is that it shows all the different phases as being exactly the same length. We know that's not the case, but it's a good optical to sort of have all of the different parts of the gait cycle in place. Now, looking at the functional ranges that are necessary for normal gait. We know many of our children don't have all these ranges intact and fully available, but yet they can still walk. So not that you have to get your child to have 30+ degrees of hip flexion, or 10 degrees of hip extension. That doesn't mean they cannot walk, but if you're addressing or trying to improve and maximize their ability, having those as your goals or your landmarks helps improve your treatment and improve your outcome. Looking at the knee, again, we know in the gait, 15 to 60. So if you've got a child who has maybe a little bit of a extension limitation, they can still walk, but you have to make some changes if you want to optimize what they're presenting you with. And at the ankle, we only need maybe 10 degrees of plantar flexion, 10 degrees of dorsiflexion. Some of our kids get to 0 and they have plantar, but they don't have dorsi, or vice versa. Know what's missing so you know what things you have to fill in. This is a typical look at what a session with me looks like. Again, it's like an athletic competition. You go in, you warm up, you do your exercises, you look for your benefit. This young lady is warming up, and instead of me doing range of motion, she's on a hill, she's pushing this barrel up and down. Now, if she steps down that hill, she's wearing AFOs with a plantar flexion stop, but she's stretching herself as she's stepping down this hill. It's not me holding her leg, putting her foot on the table and pushing on her, because yes, it's a good movement, but it's not functionally helping her do anything other than have some guy stretch her on the table. She goes up and down that hill, she's doing it on her own, and she's working on her weight shift, her balance, and she pushes it up. My typical thing with this child, I fill that with weights, and she has to really work to get that up and down that hill. Second picture, she is going down the hill, but she's got to get her body behind this and push it forward. This is the child who, when I first saw her, her mom had to carry her on the train, carry her on the bus, and hold her hand wherever they went. So imagine that. She didn't walk independently. Her mom could carry either her or her bag or her luggage or whatever she had to carry that day. So how does it affect this family and their interaction if this child, to go out with her mom, always had to be held by her mom, and after walking in several blocks, mom had to carry her on her body just to be able to keep going where they had to go. So forcing or asking her to do this kind of activity helps her to get as much as she can from this therapeutic intervention. Now you look at her down here, same girl, same session. Now she's standing on a BOSU, and I'll show you how we did this from beginning to end. And forget the fact that she's on a BOSU, watch how she recovers her balance when she loses it. Those are the things you need to work on. If she can do this on a BOSU, on the floor, walking next to her classmates, running through the playground, no problem whatsoever. When we started that activity, she was on the BOSU, I held her, obviously she needed to be held, and these frogs, she'd have to squat, pick one up, stand fully, and toss it at the barrel. Doesn't matter whether it went in there or not, but going through this circuit, and with me holding on to her to start, she was able to figure out how to control her feet, control her trunk, get nice and tall, and work on this balance activity. I think some of us would be a little bit challenged even to just stand on the BOSU, much less do a squat, stand, and throw it into a barrel. And for those of you who are wondering what's the best way to do that kind of thing, you don't carry your BOSU with you to your sessions. They can kneel on a thick pillow. They can kneel on a towel. They can kneel on the edge of a bed and do their weight shifts and rotations. So this picture on the bottom right with someone kneeling on a BOSU, it can be any surface that challenges their balance and makes them shift their weight, but try to stay as erect as possible. Same child, different day. Now she's here doing several things. She's doing her abdominal exercises. She's doing her trunk exercises. She's getting that hip extension, that hip hinge, every time she stands. And I think she's smiling. Doesn't happen often, but there she is. So work doesn't have to be difficult to be useful for this child. She's on a bench. I'm keeping her feet stable, but we're working on activating quickly those trunk muscles, getting a full extension up over her head, and getting to full hip and knee extension with the activity. Truthfully, this child also was helped by Botox. She was a toe walker, could not put her heels on the ground, could not keep her trunk erect and straight, but now she's doing this. Again, these things don't happen quickly, but you have to know what your end goal is. Same child jumping onto a short step. Sorry, I have to laugh. She always makes me laugh when I work with her. So forget the fact she's jumping on a step. That's just extra. The thing I like about this particular video is that if you watch her, she can adjust that step because she knows where it needs to be with her feet on the step and not having to hold on to me or hold on to anything else. I'm going to show it to you again. And watch when she jumps up. Nice squat. And that big step backwards, it took us a long time to get her to even feel like she could do that. But there she is. I'm guarding, but I'm not holding on to her. Okay. So when you're structuring your exercise and your routine with your patient, the warm-up has to be specific to what you want her to do or him to do. If you're doing stair climbing, you can do walking back and forth, lifting up the patient and marching, just to get them at least started and prepared for what's coming next. It's not just sit on the table. Again, I'm not saying everyone does this, but how do you move to a better place? You want to get them ready for what you're doing next. You want to get the patient strong centrally before you start doing things that require their reaching out into space and they're doing things with their full body. So if they're coming with a weak trunk, you can do planks. You can do knee lifts and holds. You can do push against me and try to see if you can move me. You can do walking, holding onto a therapy ball that's just about the proper height for them to have some assistance, but not all the work is done by the piece of equipment you're giving them. And then you can move on to your next part of your treatment. Use all that they can get built up behind them to get their whole body involved in a movement. If a child's just using their legs to try to walk, but their body's all over the place, then you're not really having them use as much as they can and should be during their exercises. If I have a child trying to push a ball down a hill with me, I'm on the other side, making sure they recruit as much as they can of their trunk, their extremities, their pelvis, their core, to get that thing to move. And I let them move it, but only when I see they've really built up as much as they can as far as their activity. Now with our patients, endurance is an issue because the movements that you need to do repetitively don't always come with riding a bike, running, jogging. That's not going to happen so easily with our patient population. But when you're making your therapy session, if you're going from exercise activity to exercise activity, you can shift it where you're using legs, using arms, using trunk, and use that as a guide to keep going, not saying, oh, well, sit down, rest for a few minutes, and we'll do something else after. You can switch up your body parts and your activity to keep them moving, and that becomes part of their endurance activity. You can still do the generic bicycle if they have a bike that's accessible to them, or you can do walking on a treadmill, which I do very frequently, or riding a bike, the stationary bike. But if you can get them to continue moving through really helpful therapeutic activities, you can also impact your endurance as well. Same child, now with weight shifting, and I said about having them work as much as possible. She's here on this step, and yes, the step is high because I want her to really work that bottom leg as well. I am using my resistance as a guide for her, if I can get this to run. So I'm pushing when I ask her to move forward, and I'm pulling when I ask her to move back. So she's working against me, but the foot on top is getting moved through dorsal and plantar flexion. I keep touching her chin and her chest to try to get her to keep up her body, so she's not just pushing and having her nose over her knees. I want her trunk up and her pushing through her pelvis. So she's pushing into me, I'm holding on to the leg, and I'm having her pull back away from me. That foot on the floor is pushing and pulling through that planted foot, and her glutes, her hamstrings, her pelvis are all active in this activity. If we look to the right, I really like this exercise. The unfortunate thing is her brother was the one with the camera that day, and she really was giggly because her brother was there. But watch what we're doing. She's on the bench. She's lifting her pelvis with that one leg through her hips, hamstrings, and pushing down into that heel. At the same time, I'm asking her to flex fully the other leg. So when we're walking, we're extending through the leg that's on the floor, and we're flexing and reaching forward with the other leg. Our patients at times flex symmetrically or extend symmetrically, and that reciprocal motion isn't really there. Here, we've gotten to the point where she can, and I've had her do very similar activities with TheraBand, with her doing a single-legged, quick hip extension movement, where she's extending forcefully, but then she's also flexing forcefully, so she's really practicing her reciprocal movement. And these things, you want to go from being horizontal to being vertical as soon as you can, but once she understands that, it's not such a big leap to go to the next step. Now, again, I think of our patients as athletes, and if you limit what you expect them to be able to do, it puts you into a box that's really limiting for you and your patient. I like these 3 videos because it reminds me that some things are limitless, and with enough work, there are things that can be achieved that you would not believe to be achieved. Now, this gentleman is holding a record. Now, that pile is 5 feet tall. And I really like the fact that I found someone who was able to do this. And the gentleman who's interviewing him, he gave him some instruction, and he was able to increase or improve how he jumps. I'm not saying our kid's going to be jumping 5 feet high, but if your child, your patient can't step onto a step, we need to figure out how we can get them to do that. We don't need to limit ourselves in what our expectations are. Top right, one leg, not quite 5 feet, but I'm still impressed. So again, hard work, good alignment, good movement. These videos, I have the links to them on the back of my information page, only because the conversation they're having about how this is done with the biomechanics and with the other researchers who research this gentleman, I think will be helpful for our therapeutic education and to help our kids. On the bottom, again, similar to what I had my young lady doing with the red barrel, but this was a competition between a weightlifter and a football lineman. And the only reason I bring this up, we can't necessarily improve our patients' performance by having them lift weights only. There's studies out there that talk about, well, we had strength training done and it didn't really show any difference, but if you look at how some of them were done, it's just gastroc strengthening and one movement strengthen or one muscle strengthen. When these football players are doing this barrel flipping, the tire flipping, they're using not their arms to lift the barrel, they're holding onto it and they're pushing with their legs and their pelvis, and they have a stable trunk that they have their core engaged. The only reason I liked using this for my patient is that when she learned to do that activity where she's stabilizing her core, where she's using her legs to try and lift something, stair walking became much easier. Standing and being stable became much easier. And her endurance actually picked up. So if you can get your patients to be able to utilize their whole body, not just a leg, a foot, an arm, okay? Again, like I said, bodybuilder versus football player, I'm not so impressed with the activity, but when you hear the conversation about how the hip hinge is part of a training regimen for football players because of the force they undergo, any sport that spends that much money on their players and on their games has done research knowing how to train someone to get as much force from their body as possible. Why waste the opportunity to use what they've learned to help our patients? These information I spoke about for the Thomas test is a good graphic I found I think you'll all enjoy. The Gait Cycle image that I showed you, the test, the pediatric balance scale, and those YouTube videos. I believe this is the first in several videos that we'll be able to flesh out different ways of moving your patients through the exercise and therapy program that you're building. So hopefully we'll continue this moving forward. Thank you very much for your attention.